Thanks so much, and I appreciate the last few comments about bringing voice to advocates and to participants, and I hope in my talk to do that. I wish I had some of these faces you're looking at right now with us, but I'm going to let you hear their voices today. So I'm going to talk to you about the FRESH cohort. FRESH stands for Females Rising Through Education, Support, and Health, and we're on the cusp of launching a cure trial, and that's why I think I was invited to participate. We've already heard from Liz that there's huge gender disparities with females being disproportionately affected, particularly in sub-Saharan Africa, where if you just look on the red versus the blue on the left, that women are multifold more likely than their male counterparts of the same age to be infected with HIV. When thinking about creating the FRESH cohort, what our task was to see if we could create a cohort of HIV-negative young women who were at extremely high risk of HIV infection, to follow them longitudinally and do very frequent testing, and to obtain pre-infection samples. And the purpose of that was to detect acute infection that would enable us to study early events important to prevention and cure research.
Negative young women who are at very high risk of HIV infection.
I'm sorry, can you repeat that?
Excuse me, Dr. Dawn, can we mute that line, please, Corrine, or?
Shall I continue?
Please, thank you.
Okay, great. All right, so in order to do that, to study very frequent infections, you need a very hyper-endemic setting. And KwaZulu-Natal is a perfect place for that. If you look at the graph on the right, that shows the infection rate in 2009 in antenatal clinics in KwaZulu-Natal, one hospital in particular, Prince Mshini Hospital, and the antenatal infection rate was almost 70% at that time. It's much lower. It is lower now, but it was that high, and that's 5 years into the government ARV rollout. This is a shot of what it looks like on the coastline in Durban and Prince Mshini Hospital, and where the FRESH study is located in relation to where those stats were gathered. Young women in our area are 20 times more likely to drop out of school than their male counterparts. A third of them, if they make it to their final year of high school, are not going to pass. And 45% of them, and that's a gross underestimate, are unemployed. The year we started FRESH, 21%, there was a 21% increase in teen pregnancy. So our question was, can we enroll those who are at very highest risk of HIV, who most need cure, in biological research and cure research? Is that possible? We know they're at risk, and we have an idea what they need, but it was our view that if we want to intervene, we have to understand and appreciate what they want, not just what we believe they need. So the idea for starting the cohort was to combine basic science research with social good, because what young woman wants to come to a clinic twice a week? Well, nobody. So we thought, what can we provide that they need and that they believe they want? And that was to combine an empowerment program for these women that provides life skills, career exploration, job readiness, and poverty alleviation. And we drew the curriculum from some best-in-class poverty alleviation programs, both in the US and in Africa. The execution of that, again, there's tremendous stigma. Young women don't want to go to clinics. So we built this in a mall. This is a look, you can see in the back where it says FRESH. This is a normal mall where the girls would go normally, not a clinic where there's a lot of stigma. It looked like this before we started, and it was a wreck, and we rebuilt it specifically, thinking of the patient and thinking of what they might do and where they might come. So we put it back together, and we said, well, we want to make this local. Let's make the furniture and everything embedded as to the local environment. These are the benches. This is the clinic, and it's a perfect fit. Would the girls come? In fact, yes, they would. This is the waiting room or the large hallway where the FRESH clinic operates. Great, looks good. We have these nice benches, but can we detect acute HIV infection during SPBIG stage 1? If you look at the graph, the red line shows when the virus is replicating exponentially. And we understand that the game is won and lost right there. And could we possibly get women when they have been just newly infected and study those time points? And how would we do that? So yes, it works. As of today, we started the FRESH, and the first group started in 2013. We've detected 89 hyperacute infections. The horizontal lines show how many days we've monitored the participants until they were detected. And as of this month, we've enrolled over 2,000 enrollees with an incidence rate of a little over 8%. 81% of them have been detected during phoebic stage 1, and the median time since they were last HIV RNA negative was 4 days, and they've been started on ARV treatment a median of 1 day. And why is that important? Because we're trying to minimize the size of the reservoir to have a cohort of women who have the greatest chance of a cure being effective. And I just want to give you a better look of what it looks like in Durban if you've never been.
I'll rise unafraid, I'll rise up, and I'll do it 1,000 times again.
In the Umlazi Township near Durban, the Reagan Institute launched the FRESH study, enrolling young women at high risk of HIV infection. Because young women in South Africa are disproportionately infected with HIV, it's paramount to include them in research, including efforts to develop novel treatment and prevention options.
We need to strengthen it and really support it because it will give us answers and also show us direction how to go in terms of intervention.
We are very excited to introduce early treatment to our participants because it provides benefit to them, but also because we are addressing a very important scientific question regarding the science of HIV cure. But our goal is actually to prevent new HIV infections. So we are very, very careful to do the best that we can to prevent people from getting infected with HIV in the first place.
I see myself in them a lot. I'm also a fresh graduate. They're like my little sisters. It's very important for me to push hard so we can protect them from getting HIV.
They have been taught that you can rise up above what you see here at home. You can rise up above any circumstances and you are able to light up regardless of what is happening around you. You're able to rise up above it.
So if we have programs like FRESH focusing on HIV negative young people who are at high risk of getting infected, I think we'll really be winning.
Visiting FRESH was amazing. It motivates me to work harder in the lab and to make progress faster in the lab.
A lot of science is people actually putting hope in scientists in order to make the next advance and in order to make the next discovery that will change the epidemic.
All we need is hope. And for that we have each other. And for that we have each other. Yeah, I'll rise up. Highlight the day, I'll rise up.
It's completely different when somebody hears about the problem versus when they come here. It changes their perspective. This is what we want to do. We encourage that. We want people to come here and see for themselves what we are trying to do, what the challenges are. It gives hope. It's what we want to do.
We'll rise up. In spite of the edge, we'll rise up. And we'll do it 1,000 times again. For you, for you, for you. 1,000 times again.
Okay, I hope that gave you a little view of what it's like where the FRESH women come from. To give you a program overview of the key events, again, we launched the study in December 12 and started recruiting. For the next 19 months, we didn't have permission at that time to provide early treatment. And by the time we had permission to give early treatment, 14 young women became infected. Once we had permission, we began providing early antiretroviral treatment. And over the next 47 months, 58 more women became infected and we started immediate treatment. PrEP is not available through the government, and it wasn't at that time. We got permission again to start providing PrEP as of June 2018. Subsequent to initiating PrEP, over the last 19 months, 17 more young women became infected. What is the procedure? Phase 1 is the surveillance period for these young women who are at high risk, to screen, enroll them, draw pre-infection samples, which you see in red, and throughout the time period, the 9 months, when they're going through the empowerment program, their fingers are pricked twice a week, following the same protocol that Jintanad's group in Thailand did to detect hyperacute infection. If any of the women become infected, they immediately began a different sampling protocol, still having their fingers pricked twice a week so we can follow viral dynamics, but more frequent sample collection during that very early period with those precious samples. This is the very first group that was enrolled in FRESH. And this just gives you a glimpse of the 14 who are untreated, and give you a blow up of that. The red is the viral load we're looking at, and you can see that exponential replication period. Each one of the square dots shows you a sampling to give you an idea of the millions of cells that were collected that are provided to investigators who are working on cure research. Of the patients who are immediately treated, to contrast that, early treatment is started within the first detection, and it blunts peak viremia and brings down the period of viremia to undetectable within days. This graph just shows you on the black curve the untreated 14 who have continued elevated viremia without treatment. The blue line is with the standard first line regimen, and the red line with the boosted regimen. Again, driving down as quickly as possible viremia so we minimize the size of the viral reservoir. Why aren't we preventing infections at FRESH? Why are we following them, giving early treatment after the fact, when we know PrEP is effective and safe? Well, we do know it's challenging for people to take a pill, and there have been many studies that demonstrate that possibly single dose PrEP is not ideal for our setting. It may work outside of sub-Saharan Africa, but it doesn't work inside with young women. In surveying the women, we asked them, what are your top 3 worries about PrEP and why won't you take it? The majority say side effects. They don't want to take a pill every day, and they don't want to take one when they're not sick. Do you think you're at risk? 59% say yes, they are, and those who are not taking their primary reason is because I always use a condom, but we know they're unprotected yet. We're failing to protect the young women. The stats tell us that without a question. The women tell us if they could choose the way PrEP was taken, most of them would want an injection every 3 months. Why? It's what they're familiar with. It's how they, the most common birth control is taken every 3 months. They don't want an intravaginal device, and they don't want to take a pill. But not everything comes out of a survey, and we're only looking at women, which is half the equation. What about the men? Let the women tell you themselves.
He was so angry, like, what happened? Where did you get this? And all those things are very, very like, boys are, I don't know, but boys are difficult. And he was so.
Sorry.
Because our boyfriends, they had trust issues. So when you start talking about HIV, he'll be like, oh, you mean you're cheating on me? When I told my friends about PrEP and told the community, they thought that I'm crazy. I'm now taking PRVs. I'm introducing them to a bad thing. They didn't think that PrEP really does exist and PrEP really works if you can take it according to the doctor's prescriptions. So it's quite difficult to make people understand. But I think that PrEP is ARVs.
Yeah.
The problem is, I can talk to my boyfriend and tell him about PrEP, and PrEP is not available in clinics. He has to go and buy it, so the life financially.
Yeah.
Yes, so it's financial stable, so not easy to go and give credit to the dog just for daily pills.
So do you find it is really expensive?
It's really expensive. It's money for grocery for months. And they even know the sound of just like you know, just like we check the container, you know, PrEP bag, the different container, like the plastic bag, like you know, not
So we've been giving PrEP at Fresh, as I mentioned to you, and these are the stats. 54% receive PrEP in initial dispensing. We have a large number who will consent to take it, but those who actually take it, receive the pills, is low and drops off each month. 18 women, as I mentioned, have been infected since PrEP has been introduced. So how are we doing? Well, it's 13 times better than in the HVTN network, who have 5% in initial dispensing. But can we feel good about that? I would say, no, we can't feel good about that because we still have so many people getting infected. We need to think about alternatives. Why are the women at such high risk? Liz has already mentioned this. There are biological factors that increase their risk, including genital inflammation and the vaginal microbiome. This is some data from Fresh showing that the majority of healthy women have cervicovaginal bacterial communities with very high diversity. If you look at on the left in orange, that's CT1 or category 1. The mostly green is category 2. And you see it getting more diverse as we move to the right to category 4. The different colors represent different bacterial species. CT1 has predominantly Lactobacillus crispatus, and then the others have a large variety of bacteria. The low bacterial diversity is associated with low inflammation and high diversity with high inflammation. So what does that mean? Well, the high diversity or high inflammation means more target cells for HIV. So what is the potential to intervene here? Is there a potential for live viral therapeutics to prevent bacterial vaginosis and inflammation in HIV-infected women? We're about to launch a trial using a new biologic to see if we can alter acquisition risk. It's a self-inserted product, and we will be starting that and have data within the next few months. But we still need a cure. And we need it, as mentioned by Liz, that needs to be where the need is and in the people that need it the most. So Fresh is a very unique platform for studying acquisition risk, immunopathology, social and behavioral factors, and it's a very patient-centered program that lends itself to study and discover new interventions. As mentioned by James, he mentioned the procedure called leukapheresis, where we're getting up to billions of different cells. In the bottom right, you can see this is the team from the South African National Blood Services, and on the right is a Fresh participant donating leukopak or leukapheresis to allow study. We collect lymph nodes, PBMCs through blood draws, and vaginal swabs. But as mentioned earlier by Dan, we need to use the right products in the right population. This is a heat map, and on the left column, you'll see down the gray, these are transmitted viruses from Fresh participants, and along the right in gray, you'll see different BNAbs or broadly neutralizing antibodies that have been tried in isolates from the Fresh cohort. And you see circled in blue some of those that are more ideal, meaning they are more potent and broader in the number of isolates that they target. These are two ideal antibodies, the Caprisa 256, CAP 256, and the VRC07 created at the NIH. And those are ones that we want to use in the FRESH cohort. So we have planned a clinical trial using dual BNABs. Again, Dan mentioned that combinations are going to be necessary. A single BNAB would not be sufficient. And using that in combination with an LRA, which stands for a latency reversal agent. So kicking those virus out and making them accessible to BNABs. This is the same map that Dan showed, and it's a model of HIV showing different target areas on the virus. And these are the two BNABs that we intend to use in our study, along with the latency reversal agent by Gilead Sciences, vesitolamod. This is just a schematic of the study design, showing that we're divided into 4 different periods. The first 2 periods are when participants who were started immediately on antiretrovirals, have been virally suppressed for at least 12 months or more, began receiving BNABs and the LRA concurrent with the antiretrovirals. During period 2 and 3 is when the ATI, or the analytic treatment interruption, begins. The women discontinue taking their antiretrovirals. And the primary aims of the study would be to firstly look at the safety and tolerability in the setting, and the safety during analytic treatment interruption. We're also, some of the endpoints we'd be looking at again is time to viral rebound. It was mentioned, what about the participants? Have they had a voice in this? Have they been consulted? What's the compensation that's necessary? How are they feeling about the ATI that we feel as scientists that is necessary? 3 weeks ago, for the very first time ever, the FRESH participants who've been acutely infected met each other. Again, I mentioned that there are a large number of them. None of them knew each other, and their confidentiality hasn't been breached in over 7 years. We contacted the acutes and said, would you like to meet each other for the first time? There was a tremendous amount of trepidation, but they came together, and we had one of the most amazing gatherings that we've had at FRESH, where the girls told their story of what it felt like to get that phone call, to be told that they were infected, and what their experience has been taking antiretrovirals. Additionally, we introduced the idea of some of the cure studies that are upcoming, and their response for participation was overwhelming. Every single one of them said that they wanted to. From this, how unique is the FRESH cohort? And the circle around here, this is one of the participants. I just want to show you some of her stats. This is her graph, similar to what I showed you earlier. She was started on treatment by the second dot you see there. She brought down her viral load almost immediately, and she's been suppressed for the last 3 years. For all the staging markers for acute infection, she's remained negative throughout, from detection and up to 250 days. Her P24 antigen, her rapid antibody test, Combi ELISA, and Western blot have remained negative due to the very abbreviated period of viremia. And I told her that if I would bring her along with me to Boston, and you could hear what she has to say.
Sibone lapho ukuthi iyenzeka lento efuna ukwenzeka yini noma yenze ngoba babehlala sithi sinovalo ukuthi into izokwenza noma ngeke izenzekile futhi kuzogcina sileke sibe endaweni eyodwa kanti le ndawo yakhethelwa khona lokho ukuthi abantu bafike nama-ideas amaningi nokuthi abantu basizakale nasentweni.
Her next message is for investigators who work in this field. She knew that a lot of people would be listening to this from around the world, and she said, I'd like to tell the researchers that we trust them and we put our lives in their hands. We want them to continue to do the great job of helping us.
Ngaso sonke isikhathi konke abakwenzayo abazi ukuthi nathi sibabhekile futhi sibakhathalele, so ekusebenzeni kwabo ngokuzikhandla nathi siyacela ukuthi bangabisanaki into eziningi kodwa bese besilekelela thina njengabantu behlekele isimo lesi sihlakala. So nje singathanda nje ukuthi baqhubeke njalo benze umsebenzi omuhle, umsebenzi oncomekayo ukuthi basize abanye abantu. Nami lokubakutshela kona ukuthi
Okay, that's what I've got. And I think I finished on time. That's the fresh cohort. We are again planning in, after we get the safety data back from CAP 256, anticipate that we'll be starting in Q4 of this year, or Q1 of 2021 with the CURE trial. Thank you.
Thank you for that outstanding presentation, because the videos definitely added a certain something that just, information slides cannot translate. So definitely kudos to you and your team for your work with the fresh cohort. We did have a couple questions from attendees. The first place, what risk factors did you look at when enrolling participants, and how was that screened, or how was WISC screened?
Is this, do you mean for risk factors for participation in the BNAB trial?
Correct.
So the women it'd be similar to the criteria for enrolling in the study itself would be no concomitant chronic illnesses, and they would, so that's the primary, is that they would be available to participate throughout. And we're working very closely with Corinne on preparing the women to ensure that they understand all the implications of participating in a trial that has an ATI in it. So we just began those conversations, but again, we'll be working closely with Corinne in the months ahead to make sure that they understand that, and that how might we be engaging their sexual partners who, if the women do rebound, would be at very high risk for acquisition. So that's one of our primary concerns is, of course, safety of the product, but safety for the women and their partners during ATI.
Thank you for that. An additional question from Jessica Salzwedel.
Hi, Dan, can you actually hear me now?
Yes, I can. Hi, Jessica.
Hi, Krista. My microphone wasn't working earlier. So that was a great presentation. One of my questions was, I saw it looks like there's no placebo group in the trial design. And I'm wondering, based on some of the data that Dan presented and some anecdotal data from Rowena and others, it seems like women control the virus better than men. And we know there's also spontaneous control after treatment. So I'm just wondering what the decision was not to have a placebo arm in the actual design.
Great question. Thanks, Jessica. And this has certainly been a topic that has been discussed extensively throughout the CURE community, through our colleagues within the I4C, and including the group in Thailand, whether or not it's critical for this study to include a placebo group. Understanding all of that, this is not a primary efficacy trial. This is a early trial to look at some of the responses, some of the immunological responses, virological responses, and to study the reservoir. So we're not looking at, our primary goal is not to be looking at efficacy. So we have opted not to include in this study design, along with consultation with Gilead Sciences, not to have a placebo group. I do understand the concern with the upcoming LACT-V trial. We are going to, it's a blinded trial, but we are looking at efficacy in that. So yeah, there will not be a control group for this first BNAB trial.
Thank you for that. Jessica, did you ask your other question? Did you want to ask your other question?
I was trying to save room in case others had a question. But I was also wondering if you could talk a little bit about the characteristics of the reservoir of this group of women, how it compares to other women globally, perhaps, and then also how it might compare to other men in the region.
I can't speak meaningfully about men in the region. We study exclusively women, in fact. and we have a lot of data from collecting lymph nodes, as well as from the PBMCs we're obtaining from leukapheresis collection. We will be starting very soon collecting gut biopsies as well to allow us a closer look at the reservoir and looking at it over time. We have not had the opportunity to do these collections longitudinally, but we will begin that so we can better understand, again, the dynamics of the reservoir. We do we do know that there is decay over time, but we haven't had the longitudinal sampling of lymph nodes nor gut biopsies at this time. We should be starting that within the next maybe 3 or 4 months.
Great, thank you.
Another question, Krista. Did the introduction of PrEP have any impact on incidence, and what were the implications to the study?
I would like to say it did. It had a very small impact from 8 to 7.9. It's been variable, and that's been non-significant. So there has been no impact from PrEP uptake. We're about to launch into a better understanding of whether the target and the way uptake is happening, does that correlate with any of behavioral risk factors? Are the women who actually go for and take PrEP the ones that needed it the most? Because we've done a lot of studies looking at correlates of infection, including use of hormonal contraception, including use of some intravaginal inserted products that are sex aids, including the presence of STIs, target cells, etc. But we haven't yet looked at whether or not the behavioral correlates linked to who is actually using PrEP. The women have told us basically this is not the product and formulation we want. They do take it. We continue to iterate to see how we can achieve better uptake. The first 2 groups that we offered PrEP to, uptake was 7 and 8%. We're like, what is going on? We can't believe it. We looked at the way we were consenting the women, and they were sitting together in a group, hearing us talk about the possible drug side effects. They kind of escalated together, like, I don't want to do that. What? Are we going to do that? Forget that. We thought, oh my God, this is terrible. Let's try. The third group we introduced it to, we did one-on-one consenting, and the uptake went up to, where the acceptance on consent went up to over 90%. So we continue to make iterative changes to try to improve uptake, but we've kind of hit a ceiling now with modifying the way we provide it to whether the women do take it and whether the fall off is as severe as it is. Again, we're doing better than the norm, but nowhere near good enough.